When we talk about pediatrics and placing the tube, so does anyone still use uncuffed tubes? So uncuffed tubes are out, cuffed tubes are in. Why? Because the technological advance in plastics basically has eliminated that ischemic damage to the larynx. And there's a great study where they randomized sick kids to cuffed or uncuffed. They found no incidence of ischemic damage, but the kids that had the uncuffed tubes had a 5-time higher rate of accidental extubation than the kids that had the cuffed tube. And when we intubate a kid, how many of you keep the kid in the same hospital? How many of you have a PICU where you work? 1, 2, 3, so a few. So most of us don't. So where's that kid going to go? They're going to go from the ED gurney onto an EMS gurney, into an ambulance, out of the ambulance, into the aircraft, out of the aircraft, into the ambulance, out of the ambulance, into the bed. There's a lot of moves that are going to happen. So that cuffed tube is critical to prevent accidental extubation. The PediStat app, so write this down. So it used to be free, now it's like $2. So I don't have my phone on me, but PediStat I think it's the best app out there. It is remarkable. Based just on the EMS report, if they give you an age, you can put the age in there. It'll tell you all the equipment, the drugs, and you can have everything out and ready before the patient even arrives. It's called PediStat. I don't make any money off of it. It's just a fantastic app. I recommend everyone gets it. All right, so now let's talk actually about placing the tube. And this comes from Leviton, and he talks about it's not laryngoscopy, it's epiglotoscopy, because the epiglottis is the only recognizable structure in that mass of slimy, red, vodka, vomit, teeth mess that we can recognize. And so what we're really looking for is the epiglottis. And the epiglottis is basically your mile marker. It's halfway between the mouth and the cords. And it sits right there basically in the middle. And instead, I used to practice and teach putting the laryngoscope blade all the way in till my knuckles were on the face and then slowly backing out and looking for it. But this is a better technique, I think, and it's advancing the blade slowly with suctioning until you find the epiglottis. Use the epiglottis as your landmark to get to the cords. So curved blade is better for tongue control. Are there any straight bladers here? All right, we got 2, 3 straight bladers, okay. More power to you. So one cool technique is, let's say you can't see anything. You go in, you sweep the tongue, you just can't see anything. So the next time you go in, instead of sweeping the tongue, take the laryngoscope blade, go right down the center of the tongue, because at the base of the tongue should be the epiglottis, and that should be a landmark to allow you to get to the cords. So that's one thing to try if you get in trouble. All right, so this is how I was taught to hold the laryngoscope, and what mechanical function is this grip really good for? Any guys carpenters? Yeah, so if you're going to pull a nail, I mean, this is ideal. This basically is a vector for pulling and lifting. And is that the vector we want? No. So anesthesiologists, they hold the laryngoscope like this. They hold it at the joint. So now, look, what are the force vectors at the joint? They're up and away. They're basically using my forearm and my shoulder to lift up. So when you're doing the stations with the mannequins with just the regular laryngoscopes, try changing your grip and being a little bit more delicate and finesse and see how much better that works. So David mentioned the external manipulation of the larynx. The Selleck maneuver doesn't work and doesn't help with aspirations and makes the view worse. The next thing was this backward, upward, rightward pressure, which was kind of a rote way of doing it. But again, from anesthesia, the most effective way to do it is for while you've got your video laryngoscope or direct laryngoscope in there, is to manipulate the structures to get the best possible view for you. And the way I do that is I take the RT or the nurse's hand, I put it on the neck, and I move it around. I say, okay, hold it there. Now I've got this hand free to go get the tube. If you do it, it's hard to teach somebody to get it right in the same spot there. And here's an example of the difference in view just with external manipulation. You can go from, maybe that's a 5% opening to almost 100% opening just with the external manipulation. All right, what about kids? Well, their airway's more anterior. We all know that. Their relative size of their tongue is larger. So basically, typically we don't have enough room for a curved blade, and we're stuck with the straight blade just for space, real estate reasons. They have a big floppy epiglottis, but that's good because it makes epiglottoscopy easier. It's very easy to find a kid's epiglottis and use that as essentially your landmark to get to the cords. So the depth, pediatric tubes have a black line on them, and if you have the wherewithal while you're intubating to appreciate that black line, you can stop right there once that black line goes through the cords. Most of us, when we intubate kids, we're like, oh my God, there's the cords, and we throw the thing in there, and you know, it comes out the rectum. But if you have the awareness, if not, you can use 3 times the tube size, and that PediStat app also tells you the depth. So I'll usually look at that, and once the tube's in, I'll say, okay, pull it back to whatever it tells me. So the shape of the tube, the curved shape, the banana shape is what some RTs will prep your tube as. The problem with that shape, and it's similar with the glide scope shape, is that you actually lose view of the cords at that very last moment before it enters the cord. So basically at the very last minute, you actually can't see the tip because your view is blocked. By using this straight to the cuff and then 45 degrees, and you can use this with either video or direct laryngoscopy, and I ask you to try this when you're at the station. Basically, you can curve that tip into view, rotate it into view. Now you can see the cords and the tip and advance it, and you have 100% visualization all the way through. So that's one thing I'd like you to try at the stations. Try that banana curve and see if you can see it go in the cords, and then try rotating it in there.